Good afternoon, Ways and Means. Hope folks had good weekends. Today is Tuesday, April 28th. It is 1 o'clock. We have some more work on our committee bill and actually relating to income tax brackets investment income today. Looking at a new draft of the bill, maybe discussing some decision points and then hearing from a few folks who work in the field. And then for the rest of the week, tomorrow we're going to try to prepare for a cannabis bill that won't get here until next week. And then we're going to be diving into Senate actions on some of our committee bills. So we're going to be prepping for the yield bill. It was supposed to be on the floor in the Senate today, but it got postponed to tomorrow. And miscellaneous tax, I think it's scheduled for tomorrow. So we'll be receiving those soon. After the floor on Thursday is we have S325 scheduled. That's the Act 181 update bill from Senate Natural Resources. If folks have concerns about that, please let me know sooner rather than later. We have very limited jurisdiction over it. It's just when permits are required or not required, there are more fees or fewer fees. And then Friday, we have the last two bills on that we have not had a walkthrough on yet, are scheduled for 9 and 9:15. So I'm hoping we can make time for that because then we will refer to all the bills. And then after the floor, we have spent some real time with the miscellaneous tax bill to see any changes they made. Not schedule for the week. Let me know if there's anything we missed. And with that, legal aid, healthcare advocate team, would you like to join us, please? Thank you. So we have this bill that seeks to sort of remedy the loss of federal healthcare tax credits, and thought you might have some thoughts about that.
Thank you for inviting us. I'm Mike Fisher, healthcare advocate.
I'm Emma Zavos, a health policy analyst.
I think my first question for you, Madam Chair, is how much time would you like us to take? Because if you just let us, we'll talk to you until dark.
Oh God, I haven't done my subtracting yet.
And if you give us 10 minutes, then we would take 10 minutes.
You could probably have like 30 minutes.
Okay.
And maybe even a little bit more than that, but I like to round down because everyone rounds up.
So I want to start with just a giant appreciation to you, to the committee, for spending time talking about this. Wherever this goes, it's really good, really important to have this kind of a conversation about what's going on in our access, our health insurance marketplaces, and what it would take to really solve some of the problems. So a giant appreciation.
All right.
So we are the Office of Healthcare Advocate. We are defined in state statute. We're not a part of an insurance company. We're not a part of state government. We're not a part of Vermont Health Connect. We have a job of advocating for improved access to care wherever decisions are made. There are 15 of us on our team, and 8 of them or 9 of them, in a way, are the helpline. So when you grab me in the hall and say I have a constituent that's got a problem, pass it off to them and they do magic. So you see me often, or you see someone like Emma or Sam, few of us, but we have an important team.
Great. All right.
Go ahead.
All right. So today we're going to talk to you about the healthcare sections of 26-0804. There are 3 initiatives in the language. I think you reviewed it on Thursday or Friday with Judge Harvey. The first is financial assistance to individuals. Second, Medicare savings programs. And the third, small employer premium tax credit. And we're actually going to go backwards and start with the small employer premium tax credit.
And folks, we had this testimony scheduled in a way that made slightly more linear sense, but then we had that fire alarm if anyone remembers, and so everything got rearranged. Anyway.
Traveling back in time.
So honestly, in full transparency, we're starting with the small employer tax credit, not because it's an area we have the least amount of comments about. And I think I just want to recognize the small group is in trouble. I think we all know it. It's in serious trouble. We see, cumulative increases of just phenomenal cumulative premium increases over the last couple of years. And we hear from employers, large and small, honestly, about how much they feel like their backs are against the wall and they don't have any.
Yeah, so the initiative that's in the language that was presented to you is a tax credit for employers that pay 50% or more of the health insurance and premiums for their employees only, it's the requirement. I believe this builds on a current tax credit initiative that Vermont Health Connect has for small businesses, but which is limited for businesses that have 25 or fewer full-time employees. And I think the average wage across that subset of employees has to be 55,000 or under. So the language before you sort of opens it up a little bit more. It cites a definition in statute that would bring the employer size up to 100 or less, and eliminate sort of the wage requirements while keeping the 50% or more contribution for its employees' health insurance.
And just to say, we have tools in the individual market. There are things we can contemplate doing, like reinsurance, like the premium tax credits that we have in place, the state subsidy for cost sharing as well. We don't have those tools in the small group. There's precious few tools that we have to deal with rates in the small group.
And now we're going to take questions on this portion because, as we said, this is the part we typically advise individuals, including employees, but we do not advise small businesses. So we've done our best to give you a high-level overview, but we'll be diving in more extensively to the other two initiatives.
And folks, we did have Austin Davis from the chamber scheduled, but he wasn't able to make it today. I'm not sure why, but
Fabulous.
yes. Yeah, go ahead.
Is there any movement to try to affect the Blue Cross Blue Shield and MVP in reducing costs?
So the other
That's the
thing that's being contemplated in this building, just FYI, is to deal with the price of care, the prices of care that hospitals are charging. And that's a conversation actually happening at this moment across the hall about how much to affect prices for 2027. And that is a tool that it is being contemplated to apply this. And that would have that impact, reducing premiums.
More than just reference-based pricing.
Yes.
So you're talking about employers up to 100 employees or 100 or more?
100 or less, I believe, based on the reference in the draft.
What effect does this have on the previous limit of, what was it, 50 employees?
I think that the limit that exists now is 25 or less, so it would just open the program so more employers could participate.
Do you have a sense of how effective the existing program is?
Really don't.
Who would you suggest we take testimony from on that?
It's gotta be a contact at Vermont Health Connect for small business.
DIVA operates it.
Yes.
And so we don't know how many people participate in it. My perspective is that it's pretty small.
Thanks.
Just wondering, in your office, what, do you get any kind of volume of calls of people that are struggling to figure out they're losing their existing premium? Can you quantify that? I mean, how, either the volume of calls you get, your estimates, what are we talking about in terms of the size of the problem we're trying to fix?
So we're going to spend a bunch of time talking about the individual market in a second, and that's where we get the bulk of our calls. And that's where I think we have some tools and this contemplated a new tool here. But I will say, we do get calls from people with employer-sponsored insurance today. And I don't have a quantification of this. But I am convinced, if you look at the landscape of where is there real problems in coverage, where is there a lack of underinsurance, I am absolutely convinced that there's a great deal of low-value employer-sponsored insurance out there. And so this proposal can only help in relieving some economic pressure for small employers that really want to cover their employees.
I understand. I know a number of small employers who just give a cash subsidy so employees can buy on the exchange. What are the pros and cons of that strategy?
I think it's taxability is the main question.
Figure out I'm not
I
prepared.
mean, we could go down this giant rabbit hole of ICRAs and Triceras. There are vehicles that employers can use to create a health reimbursement account that can be used for premiums. But it's still at the end of the day, the prices for small employers is incredibly high and has continued to go up.
I guess I'm asking a different question and the answer may be, are you crazy? And that's okay too, but why not just support the exchange and assume that people who work for small employers are going to be served on the exchange? Why do we need the small employer market?
Wow, there's a long history to that. There's a long history of employers attracting employees through good coverage. I think it is considered an important benefit that employers can give, an important attractiveness to maintain good employees. I guess I want to recognize them well outside my scope as a healthcare advocate in this discussion. But that's my understanding of the lay of the land. And that's actually, I mean, even my experience as an employee.
I'm not arguing.
Yeah.
Yeah, everybody have thoughts.
Yes.
Yeah, representative.
Like, what do you think your reasons are for Vermont having the highest healthcare costs? I mean, does that have anything to do with only having two insurance companies through the exchange?
I knew I was going to get that question. Why do we have the most expensive insurance rates in the country? And I gotta recognize that our insurance rates look higher than they actually are for two key reasons. One of them is that because we don't do age rating, and all of the rest of the country other than New York does do age rating, we look more expensive than we actually are. I can't tell you to what degree. I've always been curious to what degree, but age is a pretty big factor in insurance costs. And then the other reason is something called silver alignment. It's a tool that we're using now that very intentionally increases the cost of the silver benchmark plan, the silver plans in the exchange, in order to draw down more premium tax credits for people. And so I want to recognize those two things. Even aside from that, we have particularly high insurance costs, and it's hard for me to know. I want to go back. I want to do another double check on timing. I think I could spend a while talking about why we have high costs, and I kind of think I should talk to you more about it after.
That sounds good. Okay.
Yeah.
Do you want to go to the rest of your presentation about the individual market?
Yeah.
Sounds good.
Okay. Good.
All right, so we're gonna transition into financial assistance through Vermont Health Connect. One of the proposals in the bill seeks to enhance some of that financial assistance. So let's level set financial assistance through Vermont Health Connect. One step back. Vermont Health Connect is our state-based health exchange under the Affordable Care Act. So Vermont opted to do a state-based exchange. That's been in effect for more than a decade. There are two types of financial assistance that are offered through Vermont Health Connect. There's advanced premium tax credits, APTC, that are 100% federally funded. And then there's a state subsidy program called Vermont Premium Assistance, which exists now, VPA. And we'll talk a little bit more about that in a moment. So during the pandemic, the advanced premium tax credit was enhanced or expanded. So it became more generous for households with income less than 400% of the federal poverty level. And it became newly available, this financial assistance, newly available to households who had income over 400% of the federal poverty level. So just a couple of months ago, on January 1st, 2026, enhanced premium tax credits ended. So premium tax credit still exists, but this means that there is no premium tax credit for folks who have income over 400% of the federal poverty level. So all of those Vermonters, no financial assistance. And there is a lower amount of financial assistance for people under 400%.
Can you remind us, or Monica, could you turn around and read from the chart? about what-
We came prepared.
Okay,
We came
great.
prepared.
Please, go.
So for reference, 400% FPL in 2026 for a household of one, that's 63,840. For a household of four, it's 132,000.
Thanks.
So a little snapshot of what's happening, what happened in this open enrollment period. DEVA just published some new data as of 4/10. And what this chart shows, 2025 compared to 2026 enrollment through the open enrollment period. And so you see in the red what happened in 26. And you see what happened in blue in 25. You have a comparison. I want to just say out loud, the next couple of slides are a story of a disaster, of a real disaster happening on the numbers wise, on the insurance market, and in Vermont families. Why don't we just go through a couple slides and then.
Can I just clarify
Yeah,
the
sure.
term?
Yeah.
When you say enrollment, again, this is plans, this is not lives.
You know, I heard Nolan say this yesterday, it's lives.
Okay.
Yeah. Another view. This is disenrollment, comparing the 2 years. I want to recognize that this does not mean that there are 160 newly uninsured people. It means we have 5,160 who left this market. Some of them died. Some of them got insurance somewhere else. Some of them went to Medicaid. Some of them went to Medicare. But you have the comparison of 25 to give you a cap perspective of how different this year has been. And then finally, an income breakdown of who left. No surprise, those people above 400% of poverty are substantially the ones who previously had their income, their family share capped at 8.5% of their income and now have no cap. And there are scenarios where it can be 18, 20% of their income. Another basic healthcare 101 thing to say here is people don't leave on average. If you're a family with high healthcare needs, you know you've got a kiddo with a chronic condition or that you have healthcare needs and your prices go up 5, 8 times, you figure out how to keep paying and you stay. If you're a family that has no claims or next to no claims and your prices go up like this, it has low value to you and you leave. Insurance is about spreading risk. And if we chase everybody out of the market my main point is, this is not a story about 5,000 people who left. This is a story about the entire market being in trouble. We are in effect chasing all of the good risk out of the individual group, and it will predictably lead to ballooning prices.
Okay, that was sobering.
We go back one more.
Oh, we got a demographics brief last week.
We go back one more.
One more.
Well, no, I think that one's, but either one of these is fine. I think the other thing that just to say out loud, to even worse than this tells the story of people leaving the market. It does not tell the story of levels of coverage. And so in addition to this, we also had I think, what was it? A doubling of the number of people who went to bronze. So lower value plans. 60% of the new bronze people came from gold. So not only did we have a bunch of people leaving the market, we had a bunch of people going to lower value plans. We didn't capture that in these slides. I just wanted to say.
I said don't ask questions, but
No, ask questions. Sorry.
before the increase in the advanced premium tax credits, before they were expanded and advanced, what would the demographic breakdown look like at that point compared to now? Was it similar? Within the different plans and the different ages and that kind of stuff, and the exodus of those over 400% of poverty level.
Yeah, it's a good question. What does the status quo look like in terms of, are you asking about meta level and,
Yeah, before the pandemic and now,
Yeah.
when those advanced premium tax credits are now expired.
Yeah.
Is it the same kind of market graph and?
My guess is yes, but you would, Addie Stremulano from Diva would probably be the right person to follow up with on that. We did implement silver alignment during the pandemic years, and so that may have shifted folks a little bit more towards gold because gold became less expensive. So you might see a little bit more shifting. My guess is that the overarching number of 28,000 is probably similar to pre-pandemic, but she would be your expert.
yeah, and just to say, before this disaster that's playing out right now, we were probably at our peak coverage. The last household health insurance survey that was in the field, it's a great study. It's a professional study. We do it every 3 years. It's really where we turn to see what's really going on out there. It showed we've been bouncing along at 3% uninsured for a while. Probably that's the baseline. You're always going to have some people between coverage at any moment. But we went from 3 years previous, so I guess in 21, from a 44% underinsured rate, that is their people's deductibles and out-of-pocket exposure was a high percentage of their income, down to 30% underinsured, which is still high, but it's real movement in the right direction. We were able to move, the public, we were able to move people into better plans in the last couple of years. We've had real success.
I think another difference pre-pandemic is that our healthcare delivery system is much more fragile than it was before then too. And so the impacts of having underinsured and uninsured on sort of the overall health of the economy and healthcare system is much more dire.
And this goes without saying, but I mean, we should all, I'll say it anyway, that, people who think they're going to have no claims still get sick and still have accidents, still need care, and still have unpaid hospitals, still have bills that there's no way for them to pay. And that plays out, you're right, in a already unstable delivery system with more stress.
All right.
So premium assistance expansion is a great idea.
Indeed. So our current state-based financial assistance through Vermont Health Connect is Vermont Premium Assistance, VPA. State-based subsidy program. It lowers premiums for qualified health plans. You have to purchase the plan through Vermont Health Connect. So it's not available if you purchase directly through the insurer. Currently, it's available to households with less than 300%, with income less than 300% of the federal poverty level. It's funded with a split between the state and federal government. It's part of our 1115 waiver for that income group. And it essentially lowers a household's required contribution towards the plan. And it's used in combination with that federal advanced premium tax credit. So it helps lower your required contribution even more. It gives you a little bit more financial assistance. So we've had that in place for many years. And the proposal does not seek to change that. But
hadn't even thought of it since I sat at this table. At this end of the room, when we had the table reversed.
So the proposal is to continue that current system, such that, but to add Vermont premium assistance for individuals and households with income that's over 400% of the federal poverty level. So that's the group that just lost all financial assistance when the enhanced premium tax credit went away. This would be for households. This would make it so that households would not pay more than 10% of their income for the second lowest cost silver plan, which is how APTC is structured. And it's all very confusing. We don't have to go down that, but this mirrors that structure. Again, similarly, you'd have to purchase the plan through Vermont Health Connect, and you could not have an offer of minimum essential coverage that's affordable or adequate under the Affordable Care Act standard. That's similar to the existing APTC and EPA programs. DVA commissioned a report as they faced the possibility of the enhanced premium tax credits going away. This came to the legislature January 2025, so it's a little bit dated. The analysis was done in late 2024, but at that time they thought expanding Vermont premium assistance to make up the full cost for that over 400 FPL population would cost approximately $55.6 million. There are some states that have done that. New Mexico has done that. That's in place, I believe, right now in New Mexico. Many other states have done, have targeted some state subsidy money for people under 400%.
Questions about that?
The question from back a while, if I could just read it. You said, in your introductory paragraph or two were overly age rated. I think I heard it, but can you tell us more about that?
The Affordable Care Act allows for I'm not going to remember exactly what range it allows. It allows for a range of what people are charged based on age. And when we set up the exchange in 2011, we opted to have a more pure community rating and have people charge the same amount no matter what their age is.
Okay.
From time to time, there are proposals. There was a proposal this year that resulted in a study, I think, across the hall to contemplate doing age rating. There are pros and cons to it. But generally you're not saving the system any money, you're shifting costs from younger people to older.
Thank you. Consistent with what you've been telling us.
Yeah.
Very helpful.
Okay,
You said it's just New York and Vermont that don't do age rating?
just New York. Right. And then lastly, I just gotta say, this is our favorite time.
We spent a bunch of time on this.
Yeah.
2 years ago, 3 years ago. Yes.
You go first.
Sure. Yes, you did. And we'll talk a little bit more about where that went, which is all good news. So the last initiative in the language before you concerns further expanding Vermont's Medicare Savings Program. The Medicare Savings Program is a Medicaid-funded program. It helps people with Medicare lower their Medicare costs because Medicare is not free, contrary to the belief that many of us hold. People with Medicare are typically over age 65, or some people have Medicare if they are under age 65 and they have a recognized Social Security disability, and they've had that for more than 2 years. In Vermont, there are now 2 levels of MSP, Medicare Savings Program. There's the Qualified Medicare Beneficiary level, QMB. QMB, oh, love QMB. Pays your Medicare Part B premium. That's $202.90 a month that comes automatically out of your Social Security check, whether you like it or not. It also pays your Medicare Part A and B cost sharing at the doctor and hospital. So it reduces your costs down to $0 to get care. So much like a Medigap plan, except it's free.
So instead of that money being removed from your social security check, it stays in your social security. check.
Yes, yeah, so it's quite an economic stimulus, and we'll get to that. So the second level of Medicare Savings Program is the Qualified Individual QI1 level. This program pays your Medicare Part B premium. That's still amazing. That's like $2,500 a year in your pocket that would have been coming out. But it does not help you with the cost sharing at the doctor and hospital. So, Medicare has their deductibles, and typically you pay about 20% out of pocket for outpatient services. Another amazing thing about the Medicare Savings Program, regardless of QMB or QI1, if you enroll, you're automatically eligible for the 100% federally funded low-income subsidy list or extra health program. Prescription drug program for people with Medicare. It costs the state nothing. It lowers or eliminates your Medicare Part D drug premium, the monthly premium you would otherwise pay. It eliminates your drug deductible, and it drastically reduces your copays down to like $4 to $12. It's really amazing. We just can't say enough good things about the Medicare Savings Program.
And so just to recognize the action you took over the last couple of years that went into effect January 1st. I'm just going to focus it. I have never seen such an incredible return on investment in any public policy area. I know people often come before legislators and say there's a theoretical return of $7 for every $1 invested. Or maybe in Medicaid world, you get to say you get the federal match rate, and that's dependable. Vermont invested
Close to $5 million.
about $5 million to do the change that it just did. And just focusing on one piece of it, the 14,000 newly enrolled Vermonters. 14,000 Vermonters saving $202.90 a month. Low income, older and disabled Vermonters is $35 million in Vermonters' pockets.
This year alone.
This year alone. We spent $5 million to make this happen. And this thing is worth much more than this one item. But it is an economic stimulus. It is a low-income support program that you guys live in the world of big dollars. I can't think of anything the legislature has done recently that has this kind of a return on investment.
Yeah, the full estimate of the value is around $67 million annually. So that includes that 100% federal drug benefit program that all of those people have new access to, and also that cost sharing reduction for people on QMB. Not to mention the savings to hospitals when people can actually afford their care and they get paid for the care that's delivered. So we expanded January 1st, which was amazing. And the proposal before you in the language is to expand again, because we are not, at the top of the bracket in terms of states that have expanded their Medicare savings programs. So there's room to further expand. So the current QMB is currently set to 150% of the federal poverty level. The language suggests bringing QMB to 200% of the federal poverty level. And QI1 is currently set to 202% of the federal poverty level. The language would bring QI1 to the federal maximum that's permissible under law, which is approximately 262% of the federal poverty level. We looked around for estimates. DVHA did some estimates for various options of expansion over the last couple of years as you were contemplating the previous expansion. And they did a population estimate of QMB up to 190, QI1 to maybe 225, much lower, but still the closest thing we could find. That was about 4,000 individuals that they think would benefit. So that's very low. I think it would probably be hundreds, thousands more than that. But that's our closest estimate at this time.
So we think this is about a $10 million.
Right, yes, so the cost estimate is about $10 million. UMB costs are split between the state and federal government based on the current federal match rate. QI1 expansions are 100% funded. So that's, yeah, really great. And we ran some brief numbers for that population estimate of minimum of 4,000 or so people newly eligible, which again, we think is low. And the Part B savings alone would equal 10.3 million back in people's pocket. The prescription drug benefit is another 20 million in savings. So it just continues to add. Like Mike said, it's quite a return on investment for Vermonters. I think that's it. We'll take questions.
Anyone?
I have questions about the mechanics of the flow of money, but I don't think that's you guys.
Great questions. Yeah, Jim.
I don't think this is a question for you, Mike, but it has to do with healthcare costs, and I just want to put it out in front of the committee because I have a constituent, maybe it's urgent constituents, who are quietly irate about the difference of healthcare coverage, teachers versus, I mean, there's a bunch of groups. And at some point, I think we'll want to discuss in the appropriate forum what different groups that get their health care through teachers, through various, list of groups, the differences in premiums, and to what extent they affect tax rates, because it's part of our local budget. And it's just a discussion that we'll need to have at some point, and it's clearly not for you, but I thought it might be an opportune time to just mention that this thing is out there.
Okay.
And it's
Thanks.
not an easy one, not an easy nut to crack.
No, it's not. It's also not the topic in front of us, but I appreciate you bringing it up.
Thank you.
So I'll just say again, thank you to this committee for having this conversation. And I'll say again, whatever happens to this discussion, wherever it goes, this is really good and really important. And this is the kind of thing we need to do to stabilize our health insurance markets.
Thank you. Representative Muslin.
Other inopportune question.
Then let's just do opportune questions, and we can do inopportune questions when we're not on the agenda.
It's here anyway.
Okay. Does anyone have any opportune questions? Okay, thank you both so much.
Thank you.
Appreciate it.
Nice to see you, Mike. See you.
Kirby has an updated draft for us based on the conversation last week, which I think was on Thursday. Anyone? Okay. It really was.
Good afternoon, everyone.
Hey, good afternoon.
Got a PAT update. Kirby Heath, City Council, we have a draft 5.1 for you. I will just walk through. It should be familiar territory. It's similar to, I think we looked at a number of drafts in the last week. What we're looking at are two areas for revenue generation, changing the personal income tax brackets and the VIP tax, and also the healthcare related expenditures. But some things have been updated. So as a refresher for this version, you have changes to the income tax brackets that, for one, expands the threshold for the upper marginal bracket. So the amount of income that's in the second highest bracket is more. So is this tracking with
There's a 5.1, 6.1 question. Foot,
You're looking at 5.1.
but we have 6.1? Oh, because one's one proposal, one's the other proposal. Right? Yes, great, cool.
5.1 includes healthcare.
Yes,
6.1 is a version of the tax changes, but using that to reduce the lower income tax bracket.
yes, so they're both still on the table.
And apologies, I only printed out 6.1.
It's a different, it's a weird way of, yeah, not weird on you, just weird that it's weird that we are working to
Yeah, I know.
different proposals.
Oh, I did have to make a judgment call. I
Yeah,
couldn't
no.
get two different documents.
It's
but I feel like that would have created other confusions. So,
Great, thanks.
yeah.
Okay. Sorry.
So, yeah, so 5.1, we have, I thought there was something wrong with the brackets.
I
Apparently.
mean, I don't have the numbers memorized so far, but I don't think so.
So you're aware, again, the amount of income that would fall in the second highest bracket, which is the same rate as current law at 7.6, is higher because you have the threshold amount being 500. This is for married filers jointly. Threshold amount would be 586, 625 in taxable income. And this amount isn't accurate because it's been inflated, but it is, even the inflated amount is lower, of course, than 586. So draw your attention to that. And also, I'd like to draw your attention to the rate change in this version for the highest marginal bracket, going from 8.75 to 12.4%. And so we see a similar thing with the other brackets. This is head of household. The upper threshold is higher. So more income is falling into the 7.6 bracket. And then the upper rate is 12.4. This is for single filers. Upper threshold higher. And then 12.4.
Kirby, just a quick question. Before we had 312, so was it going 7.6? 312 and then up to be 8.75% from 312 and then up to 12.7 over 586. Wasn't that what it was for? No.
There was a version where the upper percentage was 13.3. Is that what you're saying?
Yes, but even the last version, I think was 12.7, but that started at 586. I'm just wondering if the.
For this one? I think this, I mean, Pat could help clear this up because his work is behind the numbers here.
There's still 4, it's not 5 tax brackets. I guess
There's still 4. We've seen, it's easy to conflate. I think we've seen a lot of tax brackets. I know I've drafted a
Yeah.
lot of tax brackets.
Yeah.
And sometimes there's 4 brackets, sometimes there's 5.
Yeah.
This is retaining 4.
For 5, everyone is welcome to have opinions here. Opinions are much welcome on any of this as we go. I think we've gone through it enough. We have an understanding of the basic constructs here.
Yeah, and I'm trying to focus in on the big policy change decisions in these things. So
That's in the approps and he'll be up if folks want tables rather than words with numbers.
It's hard to even know how to respond to the brackets. Because shifting the changes what you're raising, it's hard to know how to evaluate changes in raise without knowing what we're trying to accomplish to the other side. Gonna say, I'm not sure how to engage with that.
So the two, how the money gets spent options on the table are the healthcare subsidies that we just talked about, or changing the brackets to lower taxes.
we also have the estates and trusts. adjusted for this language. I think we skipped over that just last time, but it's adjusted here. Having the higher percentage rate on the highest bracket there. And that's your income tax changes. We still have the same Vermont investment proceeds tax language. But this time it has a lower rate of 3.45, which was determined based on revenue needs for the proposals. And we still have the tax base here being without any additions to the federal tax base. And so this draft 5.1 has the change to the financial assistance that you just saw the presentation on. And followed by that is the change to the Medicare Savings Program, increasing that threshold. And the small employer premium tax credit does have a percentage in this language. It was an X before. The number is 12% is what would be available to be paid for.
This is set up right now so that the VIP tax pays for the small employer premium tax credit. So that's why it's set to 12%, because that's how much that tax credit right now raises. But that's how much it can fund of this tax credit. Does that make sense? So
I think JFO will go into this, but there's an existing assessment that will be decreased due to this change, which means less revenue to the state. So that's also factored into the 12%.
Do you have these changes already in a draft form?
Pat does, and he'll have.
Yeah, Pat has an entire presentation on the numbers and explaining them. And then in section 6 of this language, we just have, we talked about this last week, a change to the tax confidentiality statute to allow some information sharing with Department of Vermont Health Access for purposes of administering the credit. And the effective date for all of this would be January 1, 2028.
So on this proposal that's in front of us, I know folks want to see the tables too. I've heard from a lot of members of the committee that the VIP tax feels too out of the box, I guess, or concerns about the impact that would have on the economy. If we remove that, is that something that people are interested in doing? We do remove it. What do we want to do about the healthcare credits? I don't know. Do folks want to wait until Pat's here and we're looking at it all as tables instead of words? Okay, cool, great. Let's look at the next document then. Unless there's more you want to show us here, Kirby.
Nope, I don't have anything else. I think the drafting decision points are pretty discrete. So we're now moving on to draft 6.1. And as we discussed a moment ago, this would be a version of things in which you're shifting some tax liability around, but not trying to pay for the healthcare changes. It's basically just paying to reduce taxes somewhere else. And I'll show you how. Within the income tax brackets, this version would decrease the lowest marginal rate from 3.35% to 2.95%, which would mean that starting at the lowest level of income, every individual earning in that range would see that reduction, no matter how high your income is, because of the marginal brackets, right? Which means that as you start to go up the brackets into the second bracket, the amount of tax, this is the tricky part, and I think we talked about this last time. this would actually be, once you build in inflation to the number that's struck through there, this is actually a reduction.
So confusing.
Yeah.
And that reduction exists up into the third bracket and somewhere, in the third bracket is where the, well, the shift really happens at the top bracket, actually. So at 586,625 in income for married filing jointly, the rate here is increased to 10%. And so one way to conceptualize this is to say, for this return, the households paying more in income tax, once they hit a taxable income of 586,625, anyone not reaching that amount of taxable income would be paying slightly less than current law. And so that same concept is played out in the other brackets. It's an increase on the highest marginal rate and a slight decrease in tax liability for other payers. And again, the thresholds are the same in both of these versions, which means that compared with current law, there is a larger range of incomes paying at the 7.6% rate than current law. We have the estates and trusts in here too. So there's that change, and then there's the VIP tax in the language here is the same as the 5.1 draft. It's set at 3.545% here as well, even though it's not being paid, it's not paying for the premium credit in this case. And effective date is the same as the other, but I would say that if you go this route, then that effective date could be earlier.
So one concern I'll put on the table about this version is, as we're possibly entering a recessionary period, it destabilizes our revenue and pretty, because you're sort of getting less revenue from the more stable base of the pyramid and less revenue from the more stable base of the pyramid and more revenue from the less stable sort of top of the pyramid. And it would lower taxes for the vast majority of Vermonters. Two things. Thanks, Kirby. Let's take a 5-minute break while we wait for Pat. Don't go